Hello, we are LING 190 Group 7, and in this presentation, we will discuss apraxia and apraxia of speech. My name is Hadar, and this project is completed with my group mates Chrissy, Beatrice, and Talissa. So let's get into it. What exactly is apraxia of speech? What causes it, how does it affect speech and sounds, and how is it treated? Our goal is to answer these questions and explore future possibilities in research, diagnosis, and treatment. First and foremost, what is apraxia of speech? Apraxia is a neurological condition that disrupts motor planning for basic tasks and movement. It impairs the individual's ability to perform intended tasks despite working muscle function. There are many forms of apraxia, all of which impair different motor functions. Apraxia of speech specifically affects the translation of speech plans into motor plans, which results in challenges coordinating and executing speech movements properly and impaired ability despite working language comprehension. But what causes apraxia of speech? Apraxia most often occurs because of lesions in the brain. This can be caused by various conditions like brain trauma, stroke, dementia, Parkinson's disease, and Huntington's disease, alongside other neurodegenerative diseases. These lesions can interrupt the brain's communication pathways, impacting our ability to control and execute planned movements. When we focus specifically on apraxia of speech, it's crucial to note that it's caused by impairment to brain regions controlling muscle movement related to speech. However, pinpointing a specific area where AOS occurs remains a subject of debate. Damage to structures within the left hemisphere, parts of the insula, and Broca's area have been associated with AOS. Its triggers range from vascular lesions to tumors and trauma, adding to the complexity of diagnosis. Brain lesions affecting multiple regions make it harder to isolate the damage responsible for AOS. What makes AOS even more intricate is its tendency to co-occur with other speech and language disorders like aphasia and dysarthria, as well as various other types of apraxia. Because of this, AOS is difficult to study. These overlaps make studying the causes more complicated because it's more difficult to determine which part of the brain is responsible for which disorder.
What and how does apraxia of speech affect sounds? Previous studies have shown that patients with AOS were prone to the following patterns of error. Errors in this case refer to off-target approximations of phonemes. Consonants. Consonants were found to be more prone to error than vowels. Specifically, affricates, fricatives, and plosives were more prone to error than nasals and liquids. Dental sounds such as the and the were also more prone to error than other places of articulation. Voiceless consonants were more prone to errors than voiced consonants as well, and substitutions were the most common error found for plosives. For example, k was perceived as t and vice versa. Consonant clusters. Consonant clusters were more prone to error than single consonants. This may be due to the clusters requiring more complex motor sequencing than single consonants. In addition, syllable initial productions were more prone to error than syllable medial and syllable final positions. Words with initial fricatives, such as the and sh, were also the most frequent errors. Multisyllabic words were more prone to error as well. Vowels. Vowels remain consistent in quality, but not as much as from those without speech issues. Specifically, oo remained consistent in quality. E also maintained typical sound when spoken alone. This may be due to vowel normalization, which refers to the ability of listeners to understand and recognize the same vowel sounds even when produced by different speakers with varying vocal tract lengths. This still allows for listeners to identify the intended vowel sound despite the speaker having a different voice or mouth shape. In terms of suprasegmentals, patients with AOS demonstrated the following errors. Prosody. According to LaPointe and Johns 1975, in their struggle to avoid error, patients with AOS will slow down, space their words and syllables evenly, and stress them equally, subsequently affecting their prosody of speech. They also struggle to express difference between happy and sad emotions through speech, which is due to difficulties in motor planning. Metrical pattern. Previous findings show that unstressed syllables of an iambic metrical pattern were more prone to error than a trochaic metrical pattern. Stress. Patients with AOS lengthened unstressed syllables to a slightly greater extent than stressed syllables. Vowel durations were also longer for vowels in initial weak syllable position of words, such as potato. Phrasing. Patients with AOS found it difficult to engage in behaviors related to phrasing, such as articulatory groping or struggling, especially at the beginning of words or phrases. It's been also found that they are aware of when their speech deviates or when they face difficulties, and they try to correct themselves, although they are not always successful. This need for correction suggests that somewhere in the planning of their speech, an error or incomplete specification of the target has occurred. Patients with AOS may also struggle with a smooth flow of speech, experiencing issues in planning and executing the physical aspects of their speech, leading to corrections and adjustments during speaking. Rate. More than half of patients with AOS spoke at an appropriately slower rate, not only physically, but they also demonstrated longer pauses between words or within words. This is typically thought to be due to disruptions in the early stages of speech. In addition, slow speech rate was not caused by muscle slowness or weakness, nor by problems in understanding of language, but rather due to difficulties in planning and executing the physical aspects of speech.
People looking for an apraxia of speech diagnoses will typically be referred to a speech-language pathologist who will run tests and diagnoses to determine if they do have apraxia of speech. Here are a selection of research papers looking into the development of new diagnostic tools. Temporal acoustic measures refer to timing the duration of voiced words and sentences. From this, the syllable rate can also be determined. Participants were asked to say words in increasing number of syllables and complexity. Overall, the PPAOS group had longer durations and slower syllable rate with words more than one syllable and complexer sentences over the control group and PPA groups as shown in Table 2 and Figure 1. Additionally, speech of the PPAOS group has been observed to have more equalized stress, placing more stress on unstressed syllables and less stress on stressed syllables. Duffy and co-authors saw a pattern in the results. As word length and/or complexity increases, for the PPAOS groups, these metrics tend to deviate further from the control and PPA group. They concluded that there is enough sensitivity with this analysis of speech to differentiate between PPAOS and PPA. The Apraxia of Speech Rating Scale, abbreviated as ASRS, was first developed in 2014 as a descriptive tool to quantify 16 features of apraxia of speech on a 5-point scale for the purposes of research. Strand and co-authors found that initial tests with clinicians showed that it has a good degree of reliability and validity. However, Strand and co-authors concede that reliability may be affected by clinicians with less AOS experience. In March of 2023, Duffy and co-authors updated the ASRS in the paper Apraxia of Speech Rating Scale, Reliability, Validity, and Utility. They retooled the characteristics from 16 to 13 and included notes on rating for assessors and also for some specific tasks. Duffy and co-authors intentionally made it so that the ASRS is not an exhaustive list of AOS symptoms, as this is meant to be a concise metric that supplements a complete AOS diagnosis. The interject reliability refers to the consistency between different examiners, and this is found to be pretty good amongst the 13 features. The feature of diagnosing apraxia of speech looks promising. The further use of temporal acoustic measures can cement it as a more objective way to assess if one's speech is similar to those with apraxia of speech. The future development and use of the Apraxia of Speech Rating Scale can establish it as a standard diagnostic tool for speech-language pathologists.
How is apraxia of speech treated? Child apraxia is a developmental condition which affects the language acquisition process. Children will benefit from intensive treatment with a speech-language pathologist, which can be up to 3 to 5 times a week. So one treatment for developmental AOS that is used is the sensory approach. And within the sensory approach, there is a method called tactile facilitation. With this technique, an SLP provides sensory cues for correcting the movements used for a child's speech. Using this method, the SLP will gently apply pressure on the child's face, neck, and head, and it improves muscular control and articulation coordination by guiding a child through targeted words, sentences, and phrases. Another method is the linguistic approach. Within this umbrella, there is the Integrated Phonological Awareness, also known as IPA. This focuses on the speech functions of phonological pattern awareness and letter sound knowledge. IPA treatments combine speech therapy and phonological awareness tasks to improve speech reading and spelling. These tasks are often positive and something the child enjoys doing, like storytelling. The last treatment for child AOS that will be covered today is the motor programming approach. An SLP may use rapid syllable transitions, and this is an evidence-based approach for children 4 to 12 years old that use nonsense words that targets precise movements of the child's articulators without the influence of existing motor patterns. Rapid syllable transitions is an intensive drill. These rapid transitions improve fluent syllable transitioning and syllable stress control within words. Moving on to adult apraxia. Adult AOS is an acquired disorder which results from brain injuries. Treating an adult with speech apraxia is situational, and the treatment is tailored to the individual's specific needs depending on the severity of the brain damage. One approach is the articulatory kinematic approach. The therapy used for this can be the multiple input phoneme. It is used for many speech disorders, including those with severe AOS. SLPs use this process by using various stimuli to promote the generalization of targeted speech sounds across different words and contexts. As initial stimuli, a speech patient's stereotypical utterances are controlled by the SLP, and step by step, the patient progresses from more straightforward to more complex sentences or phrases. As seen above, the individual will work on new words by using the initial phoneme of a stereotypical utterance. For example, one to new. Multiple input phoneme therapy aims for the individual to gradually recover and gain volitional control to produce speech. Another common approach used for adult acquired AOS is the sensory cue approach. It is a recent, most up-to-date approach using EPG. The palatal device permits close investigation of consonant productions of the tongue on the palate when the patient produces speech sounds, particularly those made with alveolar, palatoalveolar, or dorsovelar articulations. Using real-time visuals, an SLP can provide the correct tongue placement for the individuals to aid in AOS.
For the future direction of research and diagnosis in apraxia speech, we have two ideas. Regarding the causes of apraxia speech, more work can be done to pinpoint exactly where trauma to the brain causes it. There are some difficulties with this since many similar disorders show parallel symptoms, and AOS may be caused by damage to multiple places of the brain. For the diagnosis of apraxia speech, AI can actually aid in this by training in data currently available to seek patterns and associations between different test scores to determine a diagnosis. The development of an AI tool will be to assist speech-language pathologists, allowing them to focus more on treatment.
Apraxia and apraxia of speech by extension are complex disorders which significantly impact an individual's life. A lot of variety exists between patients, which makes determining etiology difficult. Since AOS can occur with other disorders, diagnosis is more difficult. Apraxia of speech can overlap with dysarthria, different aphasias, and other apraxia diagnoses. This further complicates diagnosis and research efforts. Advancements in research and technology have created a greater understanding of this disorder, such as more recent efforts to create diagnostic tools uniquely for AOS. Unlike other speech and language disorders, where patients struggle with either speech production or comprehension, those with AOS have impaired motor planning. Both their comprehension and vocal tracts are unaffected, as the problem is caused by lesions in the brain. As such, it is important to understand apraxia of speech and its intricacies, and more needs to be done in the future to properly help the people with this disorder.